Good morning. Welcome to another presentation from the University of Kentucky Corona Initiative. I am Dr. Matthew Ryan, and I'm joined this morning by Dr. Cecilia Damask, and we are going to be talking about food allergy, specifically some new developments in the treatment for peanut allergy. For this presentation, Dr. Damask and I do not have any conflicts relevant to the content of this presentation. And I'd like to turn this over now to Dr. Damask.
Great. So I wanted to start off with a story, and this is going to be a story about Paul. And Paul's a 13-year-old boy who lives in the greater Chicago area, and he loves baseball. And normally baseball and 13-year-old boys sound like a great match for fun in the summer. But for Paul, when his family wanted to take him to go see his beloved Chicago Cubs at Wrigley Field, he wasn't able to participate in all the culinary treats that typically we associate with the song "Take Me Out to the Baseball Game," because he suffers from a peanut and a tree nut allergy. And so his parents weren't able to buy him peanuts or Cracker Jack when they went to the ballpark. And for his mother, this is really frustrating. She says, that going to a sporting event, she has to be especially careful, but she states that she has to be even more careful when she goes other places like out to dinner. She thinks that going out to dinner is one of the biggest frustrations and danger zones for her, because she thinks that a lot of waiters just really look at her like she's crazy when she starts asking about what's in the different products on the menu. And so it's very frustrating. And they have been having to deal with this since Paul was 2.5 years old. When he was 2.5, he was eating some toast, or his mother was eating some toast with peanut butter on it. And Paul tried to take a bite, and he only put his mouth on it, and he didn't actually really ingest it. But his mom says right away, his face started to swell up. He started to vomit. She became very scared and took him immediately to the emergency room, where he was treated with epinephrine to overcome that episode. And for about the past decade, his mother feels she has been on constant vigilance, having to really watch out for him and educating everyone around him about peanut allergy. And she's really concerned because now he's getting a little bit older. He's in middle school. He wants to go to sports camp this summer. There are other things going on like bullying and peer pressure, and she's really concerned about the safety of it. And she is hoping and wanting there to be a day when there's going to be a cure for food allergy, so that she doesn't have to worry anymore about an accidental exposure or the possibility that her son may die from a food allergy because he doesn't have his auto-injectable form of epinephrine with him. So I thought this was a great way for us to frame our discussion about, has this day really arrived for all those millions of parents wanting to know if the day of the cure of a food allergy has come.
So, yeah, this issue of peanut allergy, Cecilia, is a big problem. It's in the news all the time. We hear about it, and certainly those of us who are parents encounter all sorts of things at school that have been implemented to try to prevent anaphylactic reactions in the school setting. But this is an otolaryngology presentation, and these are otolaryngologists who are watching this discussion we're having this morning. I want you to try to explain to us why food allergy is important for otolaryngologists.
I think knowing about food allergy and knowing about treatment options is important for otolaryngologists, because as we go out into practice and we do see patients inevitably that come to see us for allergic rhinitis, whether it's something that we treat with medical management like nasal steroid sprays, or whether we actually offer allergy testing and immunotherapy, patients are going to see us as an expert in allergies, and they're not going to differentiate, oh, they only see environmental allergies. They don't know anything about food allergies. And inevitably, if you see children in your practice, you're going to have a parent that is going to ask you about food allergy and especially about peanut allergy, because you're right, it is in all the lay press, and probably about 2% of children and teens have a peanut allergy in the United States.
Okay. All right, fair enough. Well, I'm interested to learn what you have to teach us this morning then.
So I think it would be helpful if we frame a discussion about what really is a food allergy, because just because something is a reaction to a food doesn't necessarily mean it's a food allergy. So if we take any reaction, we could start off at the top of this graphic as it being an adverse reaction. With those adverse food reactions, if it does indeed involve the immune system, then it's immune mediated, and it could possibly be a food allergy. And food allergy can be broken down into things that are IgE mediated and things that are non-IgE mediated. And it's those IgE mediated ones that cause all the severe reactions like anaphylaxis, where someone may have hives or difficulty breathing. The non-IgE ones can be severe, but they're not going to cause anaphylaxis. And I think for a lot of patients who think that they have food allergies, they may not necessarily have food allergy because it could potentially be something else, like some other reaction to a food. And a classic one would be an example of like lactose intolerance. And with someone who has lactose intolerance, the problem is that they don't have the enzyme to break down the sugar in dairy products. And so they get issues like gas and bloating and maybe diarrhea, but it's not an allergic reaction to a protein. So if you gave them a milk that had lactose removed, like a Lactaid milk, those type of patients would not have a problem. Whereas if you gave a Lactaid milk to a patient who had an IgE mediated milk allergy, the protein is still in there and they would still have problems.
So, you know, I'm a rhinologist, and it seems like you know, even in my practice, patients will come in and they'll have headaches or dizziness, or they will, you know, have who knows what, facial pain. And they'll ask me, could this be food allergy? After you discuss the prevalence of this disease, I want you to help me figure out how I can reliably diagnose or exclude food allergy.
Right. I mean, I do especially think history is going to be really important, and the type of reaction they tell you about and the timing. And so I agree. We definitely want to get to that topic. So we'll spend just a little bit of time talking about prevalence. And in the US, unfortunately, a lot of our prevalence data is based on telephone questionnaires sponsored by our government, like the NHANES, where they call and ask a sampling of Americans, does someone in your family have XYZ? Most of the prevalence data from other countries like Australia, their prevalence data on food allergy is actually incredibly reliable because it's based on oral food challenges. So this is a prevalence study that is pretty recent that came out last year, and it was based on questionnaires, over 40,000 questionnaires that were done through Northwestern asking adults about food allergy. And it suggests that overall the prevalence of food allergy in the US in adults may be close to about 10%. There was also a similar study that the same group did looking at the prevalence of food allergy with children, and found that the prevalence of food allergy in children was about 7.6% of children in the US had a food allergy. And that can translate to about 1 in 13 in a typical classroom actually having an IgE mediated food allergy. And also frequently in children who do have a food allergy, they might be allergic to more than one food.
Those are really high numbers, Cecilia. 8%
I agree.
for children, 10% for adults. That's actually higher than the prevalence of asthma.
Correct.
So, so this is not a rare phenomenon.
Definitely not. It's definitely something that you're going to get patients asking about in your practice. I agree.
Okay.
When we look at that study just in children, they did break down the prevalence of different foods in children. And it commonly has been thought that the most common IgE mediated food allergies in children, that the big three really are milk, egg, and peanut. However, based on this study that was published in 2018 in Pediatrics, it suggests that possibly the big three in children may actually be peanut milk and shellfish. And the prevalence of the different foods can change over time. And so I think that there are some questions that parents definitely do have, especially about children with food allergy. Do they have that food allergy forever, or do they outgrow it?
That's a very important question.
I
And
know. Do you have any thoughts on that?
well, I had heard that some food allergies we can outgrow, such as cow's milk or soy or egg, but others like nut allergies stick around long term. Do we have any good data on that?
So it had widely been thought for a long time that typically around age 5 or age 6, that you're right, most children outgrow a milk or an egg allergy. There was, however, a study that came out a few years ago with Bob Wood out of Hopkins. And in his particular study at his particular institution, he found that, yes, the majority of the children did outgrow milk and egg, but it tended to maybe even be later, maybe around age 10 or age 11. So, I mean, we could argue back and forth about the age, but definitely most children tend to outgrow milk and egg, whereas you're right, things like peanuts, we typically see only about 20% of children outgrow their peanut allergy, and so that does tend to persist into adulthood. There is also some data on tree nuts, and it suggests that the number who outgrow a tree nut allergy is actually less, maybe about 10%. And then we don't have any real good history data on some other foods like sesame or soy or wheat. However, it does appear that children do tend to outgrow soy and wheat, but we don't have any real good natural history data. And there are some things that you can do to try to accelerate the outgrowing of a food allergy. And there has been some evidence that has shown if children are able to tolerate baked egg or baked milk, that may help actually accelerate them outgrowing those particular food allergies.
Mm.
Yeah. So when we look at the prevalence with adults, since we do know that most children tend to outgrow milk and egg, what we're left with in adults, since most don't outgrow, only 20% outgrow peanut allergy, we see peanut allergy as one of the most prevalent food allergies in adults. And we also know that they don't tend to outgrow tree nuts, so that's also high. Shellfish and finfish also tend to be the most prevalent food allergies in adults. The peanut, though, can be, the data can be a little bit hard to tease out because some of it may actually be an oral allergy as opposed to a true anaphylactic food allergy. Do you have any thoughts on why that might be?
Well, so I've heard of something called oral allergy syndrome, and they've actually changed the name for that. Now it's called pollen food allergy syndrome.
Right.
And my understanding is that that's a reaction that occurs in the mouth or in the throat, in the pharynx, that's a result of some cross-reactivity between food allergens and aeroallergens. So you could be allergic to ragweed, for example, and if you eat a piece of cantaloupe, you get swollen lips or itchy throat as a result of that. And in general, that pollen food allergy syndrome is considered to be not dangerous, even though it may be IgE mediated, it's very rare for that to actually evolve into a full-blown anaphylaxis situation. And so someone that isn't necessarily allergic to cantaloupes, they're just allergic to ragweed. And so is that a real food allergy? I wouldn't know what to call that.
I mean, we can definitely see that with peanut because there are some shared epitopes with certain other proteins with peanut. And so some of this food allergy number here might actually be pollen food syndrome related as opposed to anaphylaxis.
Oh, one other thing, Dr. Damask?
Yeah.
Also, I've also heard that some shellfish sensitivity may not actually be a shellfish sensitivity if you're doing testing, because there's some cross-reactivity between dust mites and shellfish. Crazy as that seems.
And it's the tropomycin.
Yeah, so the muscle protein has a lot of homology from an amino acid sequence standpoint, and so that leads to cross-reactivity. So a patient who's sensitive to dust mites may also test positive for shellfish, even if they're not truly clinically allergic to shellfish.
Exactly. So I think that this might raise some concerns and maybe help us frame and maybe help us understand this little bit of data a little bit more, in that out of that paper that was published in Pediatrics in 2018, 7.6% of children in the US have an IgE-mediated anaphylactic food allergy. However, about 11.4% of parents believe that their children have a food allergy. And so why aren't these numbers matching? Why is there a discrepancy between these two numbers? Do you think that this could possibly be related to how we diagnose food allergy in the US?
Well, it could be related to multiple factors. It could be a phenomenon related to what you mentioned at the beginning, which is that adverse food reactions are often mislabeled as a food allergy. That's one thing. It is also possible that people are getting tested, and those tests are creating some confusion or contributing to some misperceptions about whether or not someone has allergy.
So could you tell us a little bit about why, when you're starting to order testing, why it's important to possibly sit down with a patient or the patient's parent and really get a good history on them? Can you tell us a little bit about what we might be looking for in the history, or what type of questions we might ask in the history?
Sure. I think, Dr. Damask, that taking a history for food allergy is very similar to taking a history for someone with suspected allergic rhinitis. And what you want to do is actually catalog the different symptoms or signs that the patient has, and then also try to establish a temporal relationship between digestion and the development of symptoms. And there are a wide range of possible symptoms of food allergy, and anaphylaxis would be sort of the ultimate, most severe example. But in my practice, I primarily use history. And so, and also I think about the plausibility of the symptoms. So if my patients, left elbow hurts and they felt dizzy for 5 minutes and they had a headache 2 days ago and they want to know if it's because they ate a banana on Monday, I try to put all that together to see if it really makes sense. And so just like, aero allergen exposures, a patient needs to have plausible symptoms that occur shortly after ingestion. And so that is, to me, the most important way to diagnose food allergy. And oftentimes in our practices in otolaryngology, patients are asking, could this be food allergy? And I'm usually trying to exclude food allergy as a diagnosis. And a simple history can usually accomplish that for me. What other pearls do you have, Dr. Damasky?
I mean, I agree with you completely. And I think that the symptoms that someone tells us, such as I ate a potentially allergenic food and I broke out in hives, or I had difficulty breathing, or I had some angioedema, definitely piques my interest that may truly be an IgE mediated food allergy. And I agree with you that the timing of that is very important, because typically ingestion and then they have a reaction within minutes, potentially 30 minutes, maybe up to an hour or two later. But you're right, if I ate something today and then I had a nondescript symptom tomorrow, it is unlikely to be an IgE mediated food allergy. And so I agree that history is really important. And the other thing is, especially when in children, or I guess really in anyone, we ask, have you had that food before? Have you had that food since? Because in children, if they have a viral illness, sometimes they might develop urticaria as a result of that viral illness. And it could have been that in that time frame, they also ate something that truly wasn't even related to that urticaria reaction, because that could have been secondary to a viral illness.
Sometimes it's not clear, though, what food triggered the reaction. And so you're an example of a patient eating strawberries and they get hives. That's easy. But what if someone went out and ate Thai food for the first time? They'd never had it before in their life. How do you parse out what component of that Thai food led to the patient developing hives and angioedema?
And quickly, within a few minutes?
Yeah, within an hour.
Correct. So
yeah.
So we do have some tests that help us parse these things out, whether we do a skin prick test or we do an in vitro specific IgE test. So in your case with the Thai food, I would want to know a little bit more exactly about what exactly they ate, try to find out those ingredients, and potentially test for what I think is possibly the triggering allergen, and only test for that either by skin prick or in vitro specific IgE testing. Meaning I'm not going to do some big panel of let me order 100 different foods and see what shows up.
Okay, fair enough. And the point for that is that we must be selective about what we test for, and we must combine that with the history. And the reason is there's a lot of issues with false positives with these tests, correct?
Absolutely. So, I mean, I think that circles back around with what you were talking about with the pollen food syndrome or the oral allergy syndrome, in that there is a lot of cross-reactivity, especially if this patient has environmental allergies. So if this patient has a birch allergy there's going to be a lot of different foods that cross-react with that birch pollen that may show up as positive. I know that you and I both have seen patients in our practice who have come in with food panels that had been done outside, and they also have environmental allergies, and all those foods showed up as quote unquote being positive without a matching clinical history. And sometimes those patients have been told to remove crazy numbers of foods from their diet, and there was no change in how they felt, but they were told by a provider to remove them because they showed up positive on a test.
So that creates a conundrum for us.
It does.
Sometimes history is very specific and will point to the food. Sometimes it's not. If we try to drill down on that with some testing to figure out, what might be the plausible food triggers, but we've got this problem now with our tests maybe giving us false positives. How do we move beyond that? What's the best way to really cement the diagnosis of food allergy?
So I think, when you get patients who have either discrepancy on their history and their in vitro, or there's skin prick test, or if the diagnosis just really isn't clear, you could proceed with an oral food challenge to be able to try to cement that diagnosis.
Okay. Another reason that food allergy hasn't been exciting to me as a topic, Dr. Damask, is that our treatment options have been really limited. If we think someone's got a food allergy, what have we done through the years? We just say, don't eat it.
Mm-hmm. I mean, you're exactly right. So our treatment has largely relied on avoidance. We've told patients to avoid it, and we've told them to carry auto-injectable forms of epinephrine with them. And if they had symptoms that were consistent with anaphylaxis, we've instructed them to use their auto-injectable form of epinephrine to reverse that reaction. But you're right. There has not been a lot of excitement in what we can do once we diagnose it. I do think that this may be a good opportunity for us to talk about two different things. One kind of reviewing what we might see in anaphylaxis, and one kind of reviewing the quality of life associated with food allergy. So do you want to tell us maybe a little bit about what exactly are those symptoms that we might see in an anaphylactic reaction, or what happens in an anaphylactic reaction?
So anaphylaxis is something a bit mysterious to many of us because we may not have seen it, and it is thankfully rare. It turns out for people who are experiencing anaphylaxis, usually you can see it on the patient. So most of the time, anaphylaxis is going to involve the skin.
Absolutely.
You can see actual wheals, hives developing on the skin throughout the body. Patients may develop a flushing or redness of their face. They may have angioedema of their lips or their face, which you can see. So cutaneous manifestations are the most common. The second most common are respiratory manifestations, and that can include laryngeal edema, coughing, outright bronchospasm with wheezing, and severe airway obstruction, basically an asthma attack. There are also gastrointestinal manifestations, so nausea, vomiting, diarrhea, abdominal pain can be seen. And in severe cases, there can be cardiac consequences with decreased cardiac output and cardiac failure. So multiple organ systems are involved. But one thing that makes hopefully the recognition of it easy for us is that we can usually see anaphylaxis on the patient's skin. Did I miss any important ones?
No, I mean, I think those are all really good points. And to a lay person, that sounds really scary. And, you know, if you're a parent of a child with a food allergy, thinking about that always potentially happening, basically 24 hours a day, I guess, except maybe when the child is sleeping, that is heart-wrenching and would create a lot of stress and a lot of anxiety. And I think that the quality of life issue related to food allergy is often downplayed because people don't really understand the burden that this places not only on the patient, but on their whole entire care system and all those that take care of the child or take care of the patient and prepare their foods. And it really touches many, many people besides just the patient themselves. And then for the patient themselves, the quality of life revolves around just about every social activity that I can think of has typically some type of food associated with that, whether that's going to a party, whether that's going out to dinner, whether that's going to a friend's house, whether that is going to camp. All kinds of different social activities involve lots of possibilities for exposure, and that is frightening for the patient. And unfortunately, a lot of what we're seeing as well as bullying that is happening for patients with food allergy, and that just adds on unnecessary burden as well. So I think you're right. I think that there are many different reasons why maybe it has not been so exciting, because we have all of these quality of life issues, and basically these patients have just been told, well, avoid it and carry epinephrine. So I think this is a great opportunity for us to tell our listening audience a little bit about some new exciting things that are going on. And so I think if we frame that around peanut allergy, I think that would be helpful. So
this is an area where there are some interesting new developments.
exactly. So peanut allergy, as we talked about earlier, affects about 2% of children and teens in the US. And so that equates to approximately 1.5 million children and teens in the US that are affected by peanut allergy. And we've been seeing an increase in peanut allergy, possibly as much as threefold over the past 10 years. And so I think this raises a question. And why is it that there is such an increased rate in peanut allergy development over the past 10 years, to the point where it seems like that's all you hear about in the lay press? Do you have any insights, any ideas as to why this may have been happening?
Well, I've heard that one possible explanation relates to the use of peanut-derived emollients or peanut oils that are used in various cosmetics, because cutaneous exposure is one way to get sensitized to a peanut allergen. Perhaps it's also because now for many years, pediatricians and otolaryngologists have been warning parents to not let their babies have peanuts because we don't want them to aspirate them down into their lungs. And one thing we do know about food allergy is that oral ingestion of foodstuffs actually leads to tolerance. And so we're surrounded by all of these foreign substances, and our immune system has to learn which are bad and which are okay. And sometimes that process goes wrong. But little babies going around sampling the environment and putting things in their mouth, they're actually teaching their immune system
Right.
what's in the environment. And so, I say that tongue in cheek that peanut avoidance has been part of the problem, but it's possible something like that is involved. Otherwise, I think it's a great mystery. Do you have any insights, Dr.
I mean, I do think that a lot of it has to do with the timing of exposure of peanut to young infants. And I think that theory stems out of data that came out of the UK. And that was data that was looking at the rates of peanut allergy prevalence in the UK versus Israel. And that really had a lot to do with the timing of when both those populations led to peanut exposure in infants, and that ultimately led to the LEAP trial, which came out in 2015. And the LEAP trial definitely showed a decrease in the rates of peanut allergy in high-risk infants who were randomized to introduce peanut early in life. And so I think that the timing of exposure of peanut allergy to young infants definitely plays a huge role. However, when we even dive into that LEAP study, there were some infants. Oh, okay.
Can you show us the data? Can you show us the data?
Sure. So that, and this kind of highlights what you were talking about before we get to that data that talks about the dual allergen exposure hypothesis or oral tolerance induction, where early cutaneous exposure to a food protein through a disrupted skin barrier can lead to allergic sensitization, whereas early oral exposure to a food allergen induces tolerance. And then also there are some other hypotheses that are on here as well, like possibly vitamin D contributing and maybe hygiene hypothesis. But here is the data that you were asking about with that LEAP trial. And I guess for people who may not be familiar with the LEAP trial, it was published in 2015. And what they did is they took 640 infants who were aged 4 to 11 months of age. And these were infants who were considered high risk. And the definition of high risk in this trial was that the infant either already had a documented egg allergy, or they had severe atopic dermatitis, or they had both. And these 640 infants were then randomized to either completely avoid peanut-containing products or to consume peanut-containing products for 60 months. And those that were in the randomized group to consume peanut products for 60 months, they had to consume approximately 6 grams of peanut-containing products per week.
And these numbers in the bottom of the slide here, are those numbers needed to treat? Are those NNT?
Yes, they're NNT.
Okay. Yeah, those are pretty strong NNT numbers. And so this study clearly demonstrated that, at least in those high-risk children who had egg allergy and atopic dermatitis, early introduction of peanut actually prevents peanut allergy. Again, getting to that idea that oral tolerance induction can occur. So take us on more about peanut allergy.
So taking us on, there was a systematic review that was published a few years ago in allergy, and it ended up including 31 different studies. And it looked at the idea of doing immunotherapy for food allergy, just like we do immunotherapy for environmental allergies or for venom allergy. It wanted to see if potentially immunotherapy for IgE-mediated food allergy could potentially be a benefit. And what this review and meta-analysis discovered was that allergen immunotherapy may indeed be effective in raising the threshold of reactivity for a bunch of different foods for patients who have an IgE-mediated food allergy and are receiving desensitization. And so I think this might be a nice segue for us to kind of talk about, well, how would you do this food immunotherapy? And, you know, the basic premise is, like we do for environmental or for venom, is that we would be exposing the patient to the food allergen that they're actually allergic to, but in very small doses and potentially increasing doses depending on the therapy. And so there are 3 different ways or modalities that this has been researched and looked into for maybe the past 10 to 20 years. And those are OIT, or oral immunotherapy, SLIT, sublingual, or EPIT, which is epicutaneous immunotherapy. And so I think if we talk a little bit about each one and the background, that might be helpful. And so we can start off talking about OIT, which is, just like it sounds, actually eating the food, starting out with very, very small doses of peanut, like maybe 0.5 milligram of peanut initially on escalation day, and then trying to slowly escalate. When they did the trials for oral immunotherapy, they started out with a very small dose, like 0.5, tried to build up to 3 or 6 milligrams, keep the patient at that dose for 2 weeks, and then keep escalating every 2 weeks. With OIT, there were some incidences of anaphylaxis and also some other GI side effects that we'll talk about a little bit later. But they did see some nice efficacy. So that's kind of oral immunotherapy. The other idea is SLIT, and I know that you might know a little bit about just SLIT in general. So can you just maybe tell us in general what SLIT would involve?
Well, we use this for patients with allergic rhinitis, and it's an alternative to subcutaneous injections of allergen. And with sublingual immunotherapy, the patient applies several drops of an allergen-containing liquid under their tongue, and that liquid is held inside the mouth as long as possible. Usually we say 2 minutes. And we want it to sit there because we want it to actually be absorbed across the epithelium, and for that allergen to be taken up by dendritic cells, and for those then to migrate to lymph nodes and do their magic in terms of inducing some tolerance to that allergen. And so we use this for things like pollens or dust mite, but it can be used for food too, yes?
Yes, and the maintenance doses might be a little bit less. So we'll get into maintenance doses with OIT when we look at the Palisade trial. But the maintenance doses for OIT are more along the range of about 300 milligrams. For SLIT, maintenance doses are much less, maybe 3, 5, maybe 7 milligrams. But you're exactly right about the process. And then one other method that has been researched is epicutaneous immunotherapy, or EPIT. There's a company now that's making a patch that's being investigated for peanut, and also one for milk. Peanut is the one that's made it through the phase 3 trials. The patch, however, is a fixed dose. So it is a much lower dose. It's 250 micrograms. And at least in the trials, the way they investigated it was they started by putting it on in the office for maybe 3 hours, taking it off, then slowly increasing the amount of time that the patient would be able to wear the patch until they're able to build up to 24 hours. Once a patient is able to build up to wearing it for 24 hours, it's that fixed dose of 250 micrograms for the duration of the patient wearing it. The side effects are much less with EPID. I mean, just as you would assume, it would be more local reaction to where the patch is placed. So I thought it might be nice for us to talk about what has actually completed their trials and just review some of the data that came out of the Palisade trial looking at OIT for peanut. And at that point, the product was an investigational product called AR101. And in this trial, there were 551 allergic patients. The majority of them were children. 496 of them were children aged 4 to 17. And when they entered the trial, they had to have a threshold of 100 milligrams or less of peanut protein triggering a reaction, meaning that when they did an oral food challenge, the patient had a positive challenge reaction at 100 milligrams or less. And then they were able to enroll in the trial. 67.2% received the treatment, and they either received the treatment or they were given a placebo dose, and this was done for 22 weeks. This was done with the updosing. So the first day in the office, they got 0.5 milligrams, watched them, built up to 6. Then they came back the next day, got 3 milligrams, stayed at 3 milligrams at home for 2 weeks, and then came back, updosed to 6 milligrams, were monitored in the office, stayed at 6 milligrams at home, came back in 2 weeks, updose challenge to 12, tolerated in the office, they were monitored, stayed at 12 at home, then came back, updose to 20. And so every 2 weeks, they were updose until they reached a maintenance dose of 300. And I think you know a little bit about what this product was like. Can you tell us a little bit about what were they doing, eating in terms of the oral immunotherapy?
Well, it's a peanut protein powder, yes?
Correct.
With a very precisely defined allergen protein content. And so unlike some homemade thing where you would take a peanut and dice it up into little pieces, with this, you actually have something that's standardized. We know what's in it. And so it's got that as a built-in safety factor. And my understanding is this is now an FDA-approved treatment for
Correct.
allergy. And so that's pretty amazing, pretty exciting that we actually have an FDA-approved treatment for peanut allergy. And you explained to us this somewhat complicated escalation scheme. What I'm curious about, Cecilia, is what are the real benefits of this treatment? Does this actually make peanut allergy go away?
So won't necessarily make peanut allergy go away. What it was shown to do was be able to increase the triggering threshold. So when you look at these patients that were involved in this trial, remember they had to react to 100 milligrams or less. So 100 milligrams or less of peanut protein would trigger an anaphylactic reaction in these patients, or in these participants in the trial. And this was done by an oral food challenge to enter into the trial. And just for some background, about 300 milligrams is what we see in a peanut. Obviously, one peanut is not one peanut is not one peanut. It depends on the variety, where it comes from, blah, blah, blah. But about 300 milligrams is the amount of protein that we see in a peanut. And so when you look at potential cross-reactivity like going out to dinner and a spoon was used to stir a dish that had peanuts, and then they made a special dish without peanuts, but they used the same spoon, that is about 30 milligrams of peanut protein. So if most of these patients were triggered at 100 milligrams, a small amount for cross-reactivity of 30 milligrams could potentially be a problem for them. And so in this trial, once they built up and they kept taking their oral immunotherapy doses daily, at the end of the trial, they then oral food challenged again to see what their triggering threshold would be. And 67.2% overall who were in the active treatment group were then able to tolerate 600 milligrams of peanut without dose limiting symptoms of anaphylaxis. And so that really would significantly give a patient some buffer. Not that they're going to go and be able to eat peanuts ad lib at home, but that they would be protected in that it would take so much more of an amount of peanut to trigger an anaphylactic reaction, that if they are able to now raise their triggering threshold to 600 milligrams, this really would protect them from accidental exposures, potentially if they went out to dinner, or if they sent the child away to camp or to a friend's house. A parent may not have to worry so much, and this might actually be a great treatment option.
So this treatment really just creates safety for people with peanut allergy and reduces the risk that they could get anaphylaxis from an inadvertent exposure.
Exactly.
Changing their lifestyle is what you've explained, and really opening up other opportunities in life. Tell me, how long does this treatment need to be used?
So this is an ongoing treatment. So, you know, there are other things in the pipeline that are being looked at and being developed that may potentially, hopefully in the future, cure a food allergy. But what we have currently available that has gotten FDA approval for OIT is something that will be an ongoing treatment to be able to keep them hopefully at a higher triggering threshold. So it's an ongoing treatment.
Okay. So like a lot of things, it only works while you're using it.
It only works while you're using it. Exactly.
Okay.
There were some side effects that were seen in the Palisade trial, and a lot of them were associated more with GI side effects, which to me makes sense because you're ingesting the product, and as you said, it's a peanut protein that is then mixed into another food vehicle. So they come in little capsules, and you open up the capsule and put the peanut in some type of vehicle and eat it. And most of the adverse events were related to GI symptomatology. And I think that you hit this on the head already, that patients and parents are really hoping that this would be a quote unquote cure for food allergy, for peanut allergy, and it's not. It's not a cure, and for the vast majority, it's not going to make a peanut allergy go away. But what this will do is raise the threshold dose of peanut that would trigger a reaction, and hopefully that would lessen the severity of a reaction if they were to accidentally be exposed to peanut protein in the future.
Cool. So potentially if baseball actually restarted and there were baseball games, he could go to the baseball game and not worry about all the peanut dust floating around in the air.
Absolutely. Absolutely.
Well, thank you, Dr. Damask,
Well,
for
thank you.
sharing all that knowledge and wisdom with us. I think as otolaryngologists, it is valuable for us to know about food allergy, at the very least, to be able to provide some advice and guidance to patients and parents when they ask about food allergy questions. And so this is actually something very valuable for us to know. And it seems like the science of food allergy is advancing, and we are entering an era where we are going to be moving beyond avoidance and actually are going to be able to intervene and change the natural history of these diseases. So thank you, Dr. Damask.
Thank you, Dr. Ryan. This was a lot of fun.
Likewise. All right, everyone, take care and be safe.
Bye. Thank you.